Yeah, I wasn't sure why they picked me, other than I had a hernia repair recently and had almost no pain, so maybe that's why. I have no disclosures, as you can see. The title of my talk is Let's Be Honest. Pain after inguinal hernia repair, open tissue, open mesh, lap, robotic, they all hurt. Well, what will we tell our patients? Don't worry, you'll cross the pain threshold in a couple years or so. So hopefully we can avoid that, but that's what we do tell them. Questions to be answered by this talk: what is the real incidence of pain after inguinal hernia repair? Are there predisposing factors? Why do patients have pain after hernia repair? What are the causes? Is there a difference between approaches? And that's the main part of this talk. Does technique matter? Does fixation matter? Does the mesh reinforcement matter? Does any of that matter? And as a surgeon, what can you do to prevent pain? I'll do that in 10 minutes. What is the real incidence of pain after inguinal hernia repair? Well, that really depends, and this is one of the most important slides. It depends on how you measure that pain, how you ask the patients, whether you interview the patients, what's the bias. It also depends when you ask them about that pain. And finally, it really depends on what you elicit of why do they have pain, whether it's at rest, activity, or sex. And these are important things because when you read an article, which you'll see in a minute, if you don't take these into effect, the articles are trash. And to look at it another way, how much serious pain do we have? And I think this was a good study. It showed that really a very small percent of patients end up at pain clinics. And it really didn't matter too much which way you had it repaired. It was a little bit better for laparoscopic than open, but that's the really serious pain. Those that ended up with a pain clinic. What are the predisposing factors that lead to post-op pain? And this is, to me, really important because it helps you judge what's the chance of your patient having pain after you do surgery. Pre-op severe pain is number 3 on the list. If they have a lot of pain beforehand, they're more likely to have pain afterwards. If they have immediate post-op pain from something you did during surgery, that's the number 2 cause. That's probably not going to go away and it's going to lead to chronic pain. But the most important factor turns out to be the age of the patient. The younger the patient, the more likely they are, in every study I've looked at, to have post-operative pain. You're best operating on old people like me because we don't complain afterwards. And if you repair a recurrent hernia, that also is more likely to have instances of chronic pain. So it's the age and the fact that they've recurred. What are the causes? And this is really the problem. There are multiple causes of chronic pain after hernia repair. Recurrence is a major cause we never think about but must be looked for. Nerve entrapment is the second. And finally, it can be related, and most people would try to tell you, especially the lawyers, it is really this, it can be related to the mesh somehow, either from rolling or folding of the mesh, irritation of a nerve, or some idiopathic reaction that an individual patient has to that mesh. But as you'll see in a minute, you have defense against those lawyers. So does the approach really matter? Let's look at open versus open mesh versus laparoscopic, and I can tell you, if there's a hernia repair, somebody is bothered to compare it to some other hernia repair. So it makes my job easier. Does it matter for mesh versus non-mesh? And here you can present, remember this study for your lawyers. At 3 years, in summary, absolutely no difference at 3 years between mesh and no mesh. So all of those that say that the mesh is causing all this pain, please refer them to this study. And the study is good because they then took the same patients with high penetration at 10 years. And guess what? At 10 years, still no difference between whether you did a mesh repair or an open non-mesh repair. The equal number of patients have chronic pain. So obviously, mesh cannot be that bad. Just a plug. Does approach really matter? Well, we've got a bazillion approaches. And someone once said that if you have a bazillion approaches, there must not be a right approach. You got the Prolene hernia system, you got mesh plugs, and you have Lichtenstein for open. All these are open approaches. And all of us have biases, and most of us have biases because we don't know what the denominator is we only see the bad complications. And if you look at the randomized studies, actually, there really isn't much difference or any significant difference between any of these approaches, whether it's a plug, whether it's a Lichtenstein, whether it's some other proline system. They all turn out to have basically the same results. The only place where you see some difference, and this is my bias, but it's what I found in the literature also, is if you compare TAP and TEP to Lichtenstein. There was, in most controlled studies, slight difference, slight better chronic, less chronic pain in the laparoscopic approach. But that doesn't hold up through all studies. Well, how about technique? And I have these arguments all the time with one of our moderators here about glue, tacks, nothing. Well, it turns out, again, I must have a bias because I think that it should be better if you don't use anything. But the randomized study actually shows that chronic pain, it didn't matter whether you tacked it, whether you glued it, or whether you sewed it. The incidence of chronic pain was basically the same in the randomized studies. Here we have glue versus suture for open repairs, and in those, glue seems to be somewhat better than suture. Again, if we look at these studies, we find that study after study, we find basically not much different by what you do, as long as you do it well. If you do it poorly, you're going to have pain, chronic pain. And one of the things that I found was that if you look at the studies, if you look at the individual randomized studies done by good surgeons, basically most of them find very little difference in chronic pain. If you take those studies, however, for time's sake, we'll skip out. If you take those studies and you look at the meta-analysis of all of those studies, which show nothing, guess what? Every one of the meta-analysis pretty much will defend whatever that person who's doing the meta-analysis wants. So what does that mean? It means if you go back to my first slide, and you look at the individual studies, you have to look at what they're studying and what they're saying is chronic pain. If you look at a meta-analysis, they are taking apples and oranges. They're mixing them together. And you and I all know, what do you get when you mix apples and oranges? You get a fruit salad. And me being allergic to kiwi, I don't like fruit salad. So I think if you're going to look at the studies, look at randomized controlled studies where they really look at something, look at what they're measuring, and then you decide for yourself. How about mesh, weight? That's been another controversy. Is there a difference? Should we be using lightweight mesh versus heavyweight mesh? And it turns out that other than the sense that a few months of difference in feel of way it feels to the patient, there is no study randomized that shows at 1 year a difference in pain, that they're the same. So don't be so worried about using a light versus a heavyweight, especially since most studies have shown the lightweights for big hernias have a higher failure rate. But that's up to you. So is it worth it to use lightweight mesh? You decide. There's probably no difference in chronic pain. To me, lightweight meshes are harder to work with, more likely to fold, higher recurrence rates for largers, but there's less foreign body initially. The patient will feel less. The best study was done out of China that showed light meshes on either side, and they could find no difference at 1 year. So again, you decide. Well, what can the surgeon do to reduce chronic pain? And I think this is another important slide. Be honest with yourself about your own results so you can know what your results are and you know how many patients really get pain. And then when you know that, you can decide how you want to change your technique and alter your technique. Secondly, use the technique which is best for the individual patient, because as I said to you, if you have complications afterwards, you're more likely to have chronic pain. So pick the technique which is best in your hands and best for that individual patient. Don't be afraid to continue to learn and modify your techniques and change. All of us think we're great, but by watching others, we can get greater. Warn the patient about postoperative pain, especially if they're young, especially if they have pre-op pain, because otherwise you will be blindsided. Don't be blindsided.
Look, check this out. Go, Rob.
Thank you very much.